Thank you, everyone, for being here. I'm Boyd Rutherford, and I'm pleased to welcome everyone to this Greater Washington Regional meeting of our Commission to Study Mental and Behavioral Health in Maryland. I want to thank our host, Montgomery College, for having us this evening, providing the space for us to do this and to talk about this critically important issue. As I've said before, the subject of this commission that we'll be discussing and continuing to discuss over the next several months and actually years, it's not always an easy topic to discuss, but this represents something that I should say an opportunity for us to make a real difference in people's lives and to truly change and reform the way we deliver services to some of our most vulnerable citizens. I like to say it's far past due that we take a serious look at how we deliver mental health services. As I say, when I say how we deliver, I also include the federal system as well, not just our state. And it's something that I feel very strongly about and an issue that is close to my heart. Over the last 4 or 5 years, 4.5 years since the governor and I have been in office, we've been working to address the state's opioid issue. And I'd say I came to understand, many of you probably already understand the relationship between the disease of addiction and mental illness. Previously, I looked at these conditions as separate and distinct. And I've learned, and as many of you already know, that substance use disorder and mental illness are often co-occurring. And for some people, it may have been a situation where people were self-medicating, where they had undiagnosed mental illness. And so we want to make sure that we, address these issues because they do not just affect the individual who is suffering, but also the families and their communities as well as their friends, I should say, too. So we want to take a fresh and serious look at how the state and the country, for that matter, bring care to individuals and families. And to that end, the administration created this commission, and the governor asked me to chair it. It was through an executive order earlier this year. And our goal is to identify ways to improve the services that affect many Marylanders that are suffering from mental illness and co-occurring conditions. And we're doing that by engaging families, advocates, practitioners, and those on the front lines of this issue. And we're holding meetings like this across the state to hear from you, the community, and to take that feedback that we receive and provide recommendations to the governor at the end of the year. We did produce an interim report. It is on my website as well as others, and we will disclose where they are. I don't remember where they are off the top, but I'll let you know. But on my website, you can find the interim report that we put out, and we'll talk a little bit about that. But I want to say that our work won't end with the year-end report. We're going to continue this commission and continue working through the length of our administration. So at this time, and actually before I move on, I saw that the county executive walked in. Thank you for being here. In a few minutes, I'll give you an opportunity to speak. But I want to let the commission introduce themselves, and we can start to my right.
Good afternoon. Lourdes Padilla, Secretary for the Department of Human Services. I'm sitting in for Dr. Randy Walters.
You want the microphone?
Yeah.
Good afternoon. I'm Carrie Guthrie-Cho, President and CEO of Cornerstone Montgomery, a behavioral health nonprofit here in Montgomery County.
Good afternoon. I'm Pat Medashevsky. I'm a family advocate, and I am also a registered nurse.
Hello, my name is Dr. Lisa Burgess. I am the Acting Deputy Secretary of the Behavioral Health Administration in Maryland.
Addie Eckert, member of the Senate representing the Eastern Shore, and I'm also an advanced practice psych nurse.
On behalf of the State Police Superintendent, I'm Major Roland Butler of the Field Operations Bureau.
Good afternoon. My name is Deborah Nelson. I'm Section Chief for School Safety and Climate at the Maryland State Department of Education and Specialist for Psychological Services, and I'm representing Dr. Karen Salmon, who's our State Superintendent of Schools.
Yeah, I'm Dennis Schrader, Chief Operating Officer and Medicaid Director for the Maryland Department of Health.
And in charge of microphones tonight. I'm Barbara Allen, and I am the Executive Director of James Place. I also serve as the co-chair of the Behavioral Health Advisory Council for the state.
Hello, I'm Serena Eckwood with NAMI, Prince George's County.
Good afternoon, Al Redmer from the Maryland Insurance Administration.
Steve Hsu with the Opioid Operational Command Center.
I'm Dr. Randall Nero. I'm the Director of Mental Health for Public Safety and Corrections.
Good afternoon. I am Dr. Tripurneni. I'm an Associate Medical Director at Kaiser Permanente, and I'm a child and adolescent psychiatrist by specialty.
Now, as I mentioned before, the commission was established by an executive order. We have 21 total members, including 6 public members, and we are tasked with the responsibility to make recommendations to the governor, advise him on how to improve the continuum of mental health care in the state, to also make sure that we consider the findings of the Maryland Behavioral Health Advisory Council in their strategic plan on 24/7 crisis walk-in and mobile crisis team services. I mentioned that we're conducting the regional meetings, and then we'll be producing reports, including the interim report that I mentioned, that we are going to do a little discussion now. And one of the questions about the interim report, and maybe, I don't see it, but I think before I get to the interim report, I think we need to approve the minutes from the last meeting. I sometimes get ahead of myself, so I have to remember to look at the agenda. Did everyone have a chance to review the minutes from the last meeting?
I second.
Okay. Any comments? All in favor? Okay, good, good. We submitted the interim report several weeks ago, and a lot of it you'll find is an update of the different subcommittees that have been created. Crisis services, families and children, finance and funding, and public safety and judicial system. And so it was, as these the workforces or the work groups were starting, they provided an update of what they have done and the meetings that they have had. The work groups are chaired by individuals on the commission, but made up of individuals both on the commission as well as other interested parties. And so I would direct people to the report. A couple of things that we did mention in terms of what we want to see explored further is the question of reciprocity, particularly with professional counselors and therapists. Right now, we do not have a true reciprocity, and so it creates a challenge for some of our providers, both on the substance use side as well as the mental health side, in attracting professionals that may be licensed in another state but are interested in working in Maryland. As we all know, we're a relatively small state, and you can get, depending on traffic, of course, to another jurisdiction in an hour, and in some cases less than that, much less than that, depending on traffic, of course. So that is something we want to explore. And I'll bring up, and I don't think I had a chance to mention, but when I was in Delaware recently, I found out about a consortium called PsychPack, and it's similar to the nursing consortium, Senator. They've started with 6 states. They're still working through the regulations, but they've agreed to have a reciprocity arrangement with psychologists, and it's something worth looking into. Delaware is currently a member. The other states are not our surrounding states, but Delaware, of course, for those who are on the Eastern Shore or northern part of our state. It's something that's worth taking a close look at and seeing if that is something that makes sense for Maryland as well. Another area that we said we would explore further is the definition for emergency facility as defined for individuals in crisis. Right now in our health regulations, the definition, or at least the interpretation, has been an emergency facility is an emergency room, emergency department. And so when you have an individual who may be in crisis, they have to be evaluated, have a physical evaluation, and it's stated that they would go to an emergency facility. Well, if you have a stabilization center that may have a nurse practitioner or a physician there, they can do that assessment and not have to tie up the emergency room, because that's another place where you could possibly lose that individual, or just the challenges associated with our emergency department. So we're looking at how to streamline that process. And then a third area is the area of parity. Parity between behavioral and physical health. We've received a lot of comments with regard to whether all of our insurance carriers are abiding by the Mental Health and Addiction Equity Act, which assures parity between behavioral and physical health. And so it's looking at that area as well. Now, I'll turn to the committee, because we had a discussion with regard to terminology and utilizing making sure we're consistent and everyone understands the terms when we talk about mental health versus mental illness versus substance use disorder or behavioral health in general. And I think, Steve, you had a chart that you wanted to. And I hope I'm not going to do all the talking around it, too. So. We will get to public comments in a few minutes, and we'll start with the county executive.
Well, that's going around. Maybe you could just offer a quick preface to the governor to this chart. Would that be helpful?
Yes.
Is that okay?
Yes, no, please go. I'm sorry.
Lieutenant Governor asked the committee to think through the terminology. I think as everyone on the committee, certainly those in the field of behavioral health, know that these various terms are rather fluid and sometimes overlapping. They can change at a high rate of speed. And our office, the Opioid Command Center, put together this chart, which unfortunately we don't have on the slides, but we will make it available on the website, but it'll be easy for you to follow as we talk through it. Prepared this chart to facilitate the discussion among the members of the commission, and reflects what we believe is the most prevailing current usage. The broadest category is human health, and human health consists of both physical health and behavioral health. Starting with physical health, a person's physical health status is neither inherently positive nor negative. We should all attend to our health. We're either physically healthy or we are physically impaired or physically ill. Similarly, with behavioral health, there are, in current usage, mental health dimensions to behavioral health, and then a substance use dimension to behavioral health. Most people today, we believe, understand the term behavioral health to include both traditional mental health as well as substance use issues. On the mental health side, just as with physical health, a person can be mentally healthy or they can be mentally ill. With respect to substance use status, there are people who use substances but are non-problematic. And there are people who use substances in a very problematic way. But not all of them have substance use disorder. There are many people who are problem drinkers or problem substance users who do not reach the clinical threshold of having a substance use disorder. So within the world of problematic substance users are two populations, non-SUD and SUD, or substance use disorder. So this is not intended to impose a definitional regimen on anyone. This is just food for thought, because I would imagine everybody in the room has a slightly different take on these various terms. So thank you, Lieutenant Governor.
Any comments? I mean, I don't claim to be an expert, so we have some experts here.
God, Pat, you started.
I'd just like to add, if they have both disorders, then it's a co-occurring substance use and mental.
Right. Yeah.
Mental illness, mental illness.
So-
Sure, I would like to speak up on this because I've dealt with it for years, and I guess my distinction is that, and I know this gets fuzzy, for the purposes of our discussion, we separate SUD, substance use disorder, and mental illness. Behavioral health was a term that brought both of those categories together, I think, because people didn't really want to look at the term brain disease. It's really brain disease, which then falls under physical health, and that makes it really complicated. But for working definitions, I think we've always sorted out what's serious and persistent mental illness, and then you have chronic and habitual addiction. But it gets fuzzy because everybody talks about we're treating mental health, but if we're really preventing mental illness and promoting mental health, then I think clarification of those terms would be helpful, because it makes a difference from my perspective, a clinical perspective, of the activities that we engage in to address both.
You don't think this addresses both?
Go.
I think this is a great start to the conversation, and certainly having, I'm sure many of us, if not all of us, have either had to start a document or had to edit a document, and it's far easier to edit a document than it is to start a document. So I thank you so much for starting. So one of the things that came to my mind as we started talking about this is, health is an ever-evolving conversation on one end. On the other end, some people say that the more things change, the more they remain the same. I think we had that conversation before we started this meeting formally. So I would say, again, this is a great start to the conversation, and it gives a framework to start talking about the other areas that are subsumed under the broad spaces on the document. And so I do want to commend you for starting that. So, for example, I would say the document allows me, I drew on it. I mean, it's just really lays to, one, being able to look at the interconnection between physical health and behavioral health. So I drew my little triangle between human health, physical health, and behavioral health, because as you said, Mr. Hsu, you not infrequently will have both. And I also drew my little triangle, it's not little, but between mental health and substance use disorder. So as Senator Ecker said, not infrequently you have them both. And so one of the things I did appreciate about the interim report is that it did highlight the fact that right now this is where we are. Right now these are the terminologies, because we know that things do change. I know that one of the issues that we discuss in the literature is really, is it a brain disease? versus behavior, and having to have that tough discussion, because then that really, in the clinical realm, that lends to treatment, right? So again, I just want to thank you so much for starting this document and allowing us to have a conversation around it.
One thing I'd also probably suggest too, looking at maybe a dotted line between mental health and substance abuse, because a lot of patients that we see that they come in for substance abuse treatment actually have an underlying mental health issue, or obviously a lot of the folks that we see for treatment with mental health problems and a concomitant substance abuse problem. A lot of times they are using substances as a way to ineffectively manage their
Self-medicate,
illness.
yep.
So it's kind of a complex interplay between the two of them. But I do think it clarifies it really well.
Yep. Good point. Sir.
Thank you, Steve. I think this is a great start. In fact, I was going to add what Randy was going to say. I would recommend adding a bidirectional arrow between the mental health and substance abuse status. The reason being, quite a substantial percentage of the members have what we call as a dual diagnosis, which is a mental health term that is commonly used, wherein there is a huge overlap. Almost by 30 to 50% of the patients tend to have comorbid diagnosis of both mental health and substance abuse. I would just add a bidirectional arrow. I mean, I realize we are not here to do an academic exercise to define. Our goal is to primarily come up with some broad categories and try to put them into buckets. I think this is a terrific start. For a lay person, this is very easy to understand.
Okay. Okay. Oh, go ahead.
So I would add one other thing, and I go back to the definition of behavioral health that SAMHSA uses, which includes one additional thing, which is pre-existing conditions. So I know it complicates things a little bit, so I'm going to follow Addie here a little bit. But we want to, if we're looking at solutions, we want to be looking at what other pre-existing conditions an individual may have. Heart disease, diabetes, or something like that. So that whatever treatment they get needs to be looked at in the totality.
Right. We had one of our commission meetings, there was talk about just that the holistic approach to health, and the idea that the primary care physician would be looking at more than just your, what is just physical, to look at the, I guess there was a better term than what I'm trying to come up with. I said holistic, but I think it was the complete care. Does someone remember the individual talking about that? You're all looking at me like my hair's on fire, and I don't have any hair, so.
Holistic works for me.
Okay.
And I think that's why we have tools like SBIRT, if you will, or doing a quick assessment of a primary care physician as an example. But we don't want to forget in the whole picture of holistic, more that I tend to, that certain underlying other physical issues can exacerbate or enhance the problem.
Okay.
Okay.
Or developmental.
Right.
Yes.
You could get developmental impairment just because of inability to accomplish some of the basic tasks of life growing up, and that makes a big difference in one's mental health. And proclivity or propensity for getting into substances complicated.
Yeah, I agree with the conversation as well. The only thing that I would like to put forth before the commission for consideration is that there are certain social determinants that really play into which of these categories you fall into at any single point in time, and from day to day can actually shift so that you fall into another category, if that makes sense. And so I'm not sure how to capture that. I'm not really good at flow charts, but just that idea.
Maybe looking at influencing factors.
Yeah, something like, yep, I like that.
Okay. All right. Well, thank you. We'll work on this to continue to make sure that we are using the terminology appropriately, and that we all understand, and that those who are reading and following along, that they understand the whole, the terminology that we're using and the interrelationships between these areas. That's not right. Okay. Now I'm going to go to the subcommittees for their updates, and we can start with Crisis Services. Steve?
Oh, sure.
If you want.
Crisis Services has had several meetings and has explored a range of issues pertaining to the crisis response system, including behavioral health issues, emergency medical systems issues. Our next meeting is tomorrow. We're very eager to have public participation. That event will take place in Frederick at the following address. 12 East Church Street in Frederick at 9:30 a.m. And we would be delighted to have anyone here join us and participate in the public session. We'll be hearing a presentation from Baltimore City and their crisis response system. Thank you.
Well, one of the things that came up in one of the previous meetings with Crisis Services was the issue of transportation. And so that may be something that we have to at least think about in terms of how people can get to, if we have crisis services like the 24/7 crisis facility, how to get people to and from. And in some cases, it may be, working with law enforcement or working with the emergency response. And that's what we need. That was the whole point of having the suggestion with regard to the definition for emergency facility, that it doesn't have to just be an emergency room, emergency department, but so that the EMT can take a person to a facility that can help them in that situation, or law enforcement can take them to that facility as well, or their family. And so, okay. So youth and families, Madam Secretary, you said you would.
Good afternoon, thank you. The subcommittee met on June 26th, and they revisited the 3 focus areas, which is K-12 education, caregivers and families, and mental health coordinators. But at the same time, the discussion shifted to other areas that the group thought that it also deserved attention, such as the need to increase awareness and access to support and services for individuals from the birth to 5 age range who may be experiencing a behavioral health concern or who may be witnessing their family member who has behavioral health concern. So that's something that the group wanted to also take on. Another area that was discussed was the mental health coordinator designated for each school system. The group wanted to look into how has it been working, what does the work group look like, and how can it be improved, since it's something that is so closely related to the focus areas. Another population that the group wanted to focus on was the transitional age group. Age 18 to 26, they thought it was important to also focus on that, on that group. And then a representative from the Department of Juvenile Services also brought up the important topic of youth in the justice system, whether they're on probation in the system or have a record. They need more services for this group, and they thought that it was very important to have that discussion as well. So I keep adding another topic, also was suicide prevention, very important, the impact that social media has on this area, and the data is not even an even distribution, but in each age band, suicides have risen, and we need to look at that. And bullying, very important as well. So the discussion will continue. A follow-up meeting would take place, and we'll take a deeper dive on the focus areas and the new designated topics.
Thank you. those are very important areas when you mentioned the transitional 18 to 26. From some of the material I've read, often a young person doesn't start showing signs of severe mental illness, such as schizophrenia or bipolar, until they're in their early 20s. And that goes hand in hand with the other area you said, with how do you help an adult family member? Because that 21, 22-year-old in the eyes of the law is considered an adult. And they feel that they're okay. You know, when you talk to them, they'll say, no, you're the problem, I'm not the problem, you're the problem. And so they feel they're okay, but everyone knows that there's a challenge. And so how do you handle that? The Federal Cure Act was supposed to address that, but I haven't found where the regulations have been promulgated that provide that service that allows for breaking through that HIPAA barrier, that the family members can get help and be able to be consulted on what is going on with a physician or provider, you know, with regard to their adult family members. So that, I'm glad that, you know, you're looking into that, and as well as caregivers. Dennis, you on finance?
Yes, sir, Lieutenant Governor. Al, I think, Al, you're going to start.
Yeah, I'll
Why don't you
start.
go ahead, and then I went first last time, and Al's been working hard and is our co-chair. Go ahead, Al.
All right, thanks, Dennis. Lieutenant Governor, members of the commission, the Financing and Funding Subcommittee has met twice since the last full commission meeting. We met on June 17th and July 15th. During that time, the Insurance Administration has received and began analyzing the second annual network adequacy reports that we have received from commercial carriers doing business in Maryland. We have reported to the subcommittee on our first impressions of the reports. It appears that there's a general trend in improvement in the behavioral health networks. However, many of the reports were inadequate and did not provide the basic information required by the regulations. Additionally, most carriers reported non-compliance with the wait time standards. The next steps for the MIA is to include follow-up with the carriers to obtain the missing information and to do an analysis of their methodology to make sure that the information contained is accurate. During the two subcommittee meetings, the MIA requested and received feedback on issues that behavioral health facilities are experiencing during the credentialing process with commercial carriers. As a result of that feedback, we're going to host a separate call specifically for the credentialing issues for behavioral health individual providers and facilities, and that will occur on August 8th. The call information and agenda are on the commission website, and anybody naturally is welcome to participate. Our next subcommittee meeting will be on August 12th. And Dennis, with that, I'll go back to you.
Thank you, Al. Lieutenant Governor, as we reported the last time, and we've continued to work diligently over the last month on bringing up a focus on what we're calling system of care in terms of get the MCOs and the behavioral health community coming together with folks who have an interest in parity to discuss how to get better service and outcomes.
And MCOs are
Managed care organizations. Thank you for reminding me. I too many acronyms. Thank you. But the managed care organizations, we just approved the new administrative services organization. You led that at the Board of Public Works last week, and there are a lot of new services that are going to be brought to bear in the administrative services organization contract with, and we'll have a new company called Optum who will be providing that service. That links into this group, and in the finance group, we're focusing on one of the four issues that were in the preliminary issues list, and that is to assess and develop quality outcome principles. And there's a sense that by focusing on quality, we can improve cost over time. And so that's sort of the thought process. We're just getting that cranked up. We're getting input. And so we're using these finance committee calls to get organized around that, and we're bringing that information back to the system of care process. Just today, we had our first major work group meeting where we brought the work group together. We've had, and there are 4 discussion groups that are supporting the work group, and there's been at least one meeting of the behavioral health community and the managed care organizations, and the Maryland Hospital Association is also convening meetings. So we have a all-hands-on-deck effort here. This group will be meeting for 4 years, and our target is to finish our work in coordination with the General Assembly, I might add, Senate Finance Committee and the House Government Operations Committee, and Senator Kelly herself is going to sit on the steering committee that Secretary Neal is chairing. And we met with Delegate Pena Melnick last week, and they're going to provide somebody for the steering committee. So we have a lot going on, and we're taking on a very large issue. But if you think about it, Medicaid spends on somatic care for managed care about $5.4 billion. And in the behavioral health side, we have the total public behavioral health system with my partner, Deputy Secretary Burgess, is $2 billion. The Medicaid component of that's managed by the ASO is about $1.4 billion. So we're talking about $5.8 billion in resources. So we'll continue to report back here, but this is providing us a very nice venue for discussing these quality principles, sir.
And that would apply also to the private side as well, in terms of the quality principles.
Well, you raise a good point. We'll be sharing that with Al as they look at how to apply that. Our focus right now is on the public behavioral health system.
Okay. Before we get to the public comments, I just want to give Senator Hester an opportunity to introduce herself. Thank you for coming in. If you want to. I kind of introduced you, but I didn't. So.
Well, thank you so much, Lieutenant Governor. Senator Katie Hester, I represent Howard and Carroll counties, and it's my distinct honor to have been appointed to join your committee. So thank you so much. I look forward to it.
Okay, thank you. And I jumped ahead of Dr. Nero there, so. Okay.
Thank you very much.
Public safety.
We had our meeting earlier this month, and we had several participants attending, which I think was excellent. What we decided to do was to put the focus on the first area that was noted in the charge to the group, which was the looking at policies of first responders related to identification of individuals with behavioral health episodes. So we had a lively discussion for a few hours, and the real focus we had there was to come up with some recommendations. And the first recommendation was to develop, or actually not develop, but to utilize what's called the sequential intercept model as a means to develop an actual mapping of available resources across the state to individuals with behavioral health issues. It's a nationally known type process that's there. The other thing we thought would be advantageous would be to provide standardized training for related to behavioral health, related to individuals in criminal justice personnel, which would be law enforcement, corrections, juvenile services, and the courts, because in terms of my agency with public safety and corrections, our parole and probation agents, although they have a degree of training associated with the mental health services, sometimes when offenders come to them for supervision, they're not really quite sure if they have a mental health issue, where might they refer them to, how do you interact with them? So we thought that was an appropriate aspect of training that should be recommended. We also thought it was important to identify civic partners that currently exist in the community, which would actually come out of utilizing the sequential intercept model. And the other part that we think is important to justify the continuation of this, of course, would be to develop a data collection system to demonstrate both the effectiveness and the decision-making related to the model.
Okay. Thank you very much. Okay. All right. This time, I'd like to invite the county executive to come up. Sorry to keep you waiting for so long.
You know, your discussion is actually interesting.
Well, this is the opportunity we have to meet together. So we have a public meeting and we talk about what happens in our work group. So,
Yeah, so I mean, I felt perfectly comfortable sitting there listening to it. I thought it was really actually helpful framing the work you're doing. I want to thank you for doing this, and I think this is a very important commission. I'll say I wish you had the abilities of the Kerwin Commission, because Kerwin's dealing with two sides of this problem, which is, A, what are the programs we need to move our children forward, and how are we going to pay for it? And the part that we need to confront, because I think we all know pretty much what we need to do. I think you all map out a reasonable way forward, and then the question is going to be, how do we pay for the reasonable way forward? And I would suggest that dealing with mental and behavioral health issues is as important as dealing with education issues. We're dealing with education issues because we lose these students in the beginning. We're losing people on the other end to behavioral and mental health issues. And both of them result in us not being able to take full advantage of the human resources that are available in our communities. When we lose people who can't do productive things, we lose the opportunity to take advantage of the skills and the intelligence they could bring to things, and we don't do it. So I hope that in the long run we really get to tackle the financial challenges that it takes to really fund some of the things that we all know we could and should be able to do. I'll just tell you a little bit of some of the fun things I've been dealing with, because I've seen this issue front and center this week multiple times and over recent weeks. I've talked with groups of high school students who talk about levels of depression and stress that I've never seen, and most people have never seen. I was regaled with stories of students who had breakdowns in school, were taken out of school by ambulances, and got to spend days in the hospital getting mental health support. And I went to school in Montgomery County, and that was not the kind of stories that people told about what was going on inside the high schools. And these kids, to a person, went around the room and talked about stress and the impact on their lives in school. And that's, I think, important that, we know we don't have the counselors or psychologists in the schools that we need to have in the schools. I was meeting with a community in Montgomery County the other day, and they were talking about the growing number of homeless and the problems they were presenting in the community, and more prominent behaviors, more behaviors that were disturbing, and talking about the impacts on the businesses and the residents that they were trying to attract there. But what I took as encouraging is they did not want me to arrest people. A lot of times, and in other days, that would have been the conversation: can you put these people away? And instead, they said, you've got to find a way to treat these people. They need help, and we need the resources to be able to help them. And we need programs to be able to help them. I operate one of the largest mental health facilities probably in the state. Not the largest, because I think you have a bigger one.
Second to our state
But
penitentiaries.
But ours, 1/3 of the people in our jail present with mental health issues. They really don't belong in jail. And if they got the treatment, if we were able to support them in mental health issues, they wouldn't be in jail. And the resources that we spend to put people in jail is enormous. And you got to wonder, if we took those same resources and put them in mental health, what would we get? And the same thing is true with homelessness. When I arrest somebody for not complying with not appearing in court and they get a bench warrant, what I'm going to spend to put somebody in jail overnight or for 2 or 3 days is probably equal to what I could have put them in a good hotel in Montgomery County for a month. And they're going to go back and through this. We need more support for police crisis teams. We talk a lot about, more and more our police go out in the field. They encounter people who present mental health issues. They don't have the resources to deal with them. We don't have enough crisis teams to get there or get there in time because what we have has to be in the right place and the right time to arrive there before an officer winds up doing something they would probably rather not do. And these are real life and death decisions to get made simply because in some cases we weren't able to get the right resources to that place at the right time. So these are all real things that we deal with. And the last thing I'll talk about is, knowing people in the mental health who deal with folks who present both disabilities, but also mental health issues. And some of them receive services, but if their allocation for services runs out because they've spent what the agency can spend in dollars on getting a person in front of a psychiatrist or whatever the help they get, they will go for a period of time until the next cycle begins for their funding. And I've heard people say that what they hope is that they get arrested before they do something to hurt themselves or somebody else, because they go through a period where their mental health declines and it's not being treated. And so what you hope for is they wind up in jail. That's not what any of us want, and it's not what they want. So I'm here just, I see the human face of this all the time. I know from your resumes and what you've done, you all see the human face of it. So I want to encourage you, to work on developing plans that more effectively help us address these issues in the community. And to the extent you can, we need to get our legislators to summon up the courage to provide the funding. This is a bipartisan problem. I can't point to any administration that fully addressed these issues. So this is just simply, we've not faced up to stuff. It's time for us to face up to it and figure out what's it going to take in resources in order to do the right thing for these people, because ultimately it's going to be the right thing for our community. So thank you for giving me a few minutes, and I really do appreciate the work you're doing.
All right, thank you very much. And I just want to say that, in the slightly differ with the current commission, is that we are looking at the detail in terms of what's the best way to go forward before the, throwing money. There are places where we do need additional resources, but there's also, this has been, as you said, well past due, that, and the folks here know it better than I do, that starting in probably the mid to late 60s, where we deinstitutionalized, the institutions were not great because we were warehousing people and there were all kinds of abuses, but we didn't have the warm handoff of where the individuals would go. They were supposed to go into community organizations, community health services, and they didn't always go there, or there weren't enough, or they didn't have the resources to take them. And then, if you remember the 70s, and now the homeless situation and individuals, and then the only place was to the jails. One thing that the administration is doing with regard to the Baltimore City Jail, the only jail that's run by a state agency or a state, is with the new jail, that building, instead of a new just purely lockup, that 40 to 50% of the beds will be for mental and substance use disorder, because a person may commit something that is a crime, but their real issue is treatment. And they're only in the jail for about 6 months on average. And so if you don't address that issue, they return. But one of the problems, and like you said with the individual who was saying that they would want to go to jail before they do something, is the standard for commitment is that they have to be a danger to themselves or an imminent danger to themselves or others. And so this individual knows that right now I'm not a danger, but I can be, but there's no way to get them. So we're looking at how do you address that individual as well. How do you address the individual who can't really care for themselves? So it's coming up with the plan and then the resources to implement those plans. But thank you very much, and you definitely see it. You're facing it up front line. Do we have other elected officials that I didn't know or hear? Okay, then I'll go to the list that I have. And the list doesn't mean that you can't speak. These were just people who signed up to speak. Arthur Ginsburg.
You have me following the county executive. That's a tough act. Hello, my name is Arthur Ginsburg. I am the president and CEO of CRI. CRI is a nonprofit behavioral health provider in Anne Arundel, Baltimore, and Montgomery counties. A majority of the patients we serve are publicly funded Medicaid patients. I am here today to encourage this commission to tackle comprehensive reform, making the investment needed to build the strong, accessible behavioral health system that Maryland needs. The Certified Community Behavioral Health Clinic, CCBHC model, embodies the structure and investments needed in Maryland. CCBHCs ensure that access to a treatment is available at times and places convenient for those served, prompt intake and engagement in services, post-discharge follow-up, access regardless of ability to pay and place of residence, crisis management services available 24 hours per day. With a CCBHC level investment in creating a stronger, more transparently accountable system, Maryland's community behavioral health providers will be in a position to reduce hospital admissions, reduce readmissions, and reduce emergency department utilization. I urge this commission to include comprehensive solutions like CCBHCs in your recommendations. Thank you for your time.
Let me ask you, just before you sit down, how does one normally how do you get patients? How do they come into the door?
Right now, CRI is not a CCBHC provider.
I'm sorry. Okay.
So I wouldn't be able to answer that question. Sorry.
All right. Because I asked that because it goes back to the definition that we were talking about with emergency facilities, that if a emergency personnel, first responder, the ambulatory service, they bring a person to one of those facilities right now, they typically won't bring them to those facilities.
Correct.
Because of the definition to take them to an emergency room, and so we're trying to address it so they could possibly go to another facility first. Okay, Carol, I'm sorry.
It's okay. No, so just to respond to it, right now in Maryland, there aren't any CCBHCs. There are two providers who have funding from the feds to potentially become CCBHCs. That would be Cornerstone, Montgomery, and Mosaic Community Services. But what the model requires is that people can walk in your door and be treated and seen, especially in an emergency,
Right.
same day. In an emergency, they should be treated, they should be seen, so it's a 24-hour. Now, if it's not an emergency, it's your quote-unquote, just a regular referral for ongoing services, there's a different time limit, but even that is supposed to be fairly quick. There should not be a delay in services like we hear about now that takes 6 weeks to see a psychiatrist, and there's different models that allow for that structure to happen, that scheduling to happen. And then there's different things when you're talking about police. I know in Oklahoma, one of the CCBHCs there, they have an arrangement with the police where every police car has a tablet, and if they come across someone who they, believe is a mental behavioral health issue, they link immediately to a provider via the tablet, do an assessment, and then they potentially would take them to wherever that service would be. So the diversion happens on the street, not even in the ED, not even at the diversion happens before anything else happens. So there's a lot there's models all over the country. There's 8 states that are doing the CCBHC model, and all of them have different ways that they've been putting these requirements together and measuring outcomes and all of that. But there are expectations, if you are a CCBHC, of how quickly you see people, and they delineate between an emergency situation and a quote-unquote regular referral. Extended until September.
Speak it up a little louder so others can hear.
Congress just extended their funding. Those CCBHC.
The 8 states is extended until September, when the real budget will be discussed, I guess. It was supposed to end the end of June, and they did extend the 8 demonstration states through September because there's a big push in Congress, the Senate in particular, to expand it to more than 8 states and to keep it going, not just have it be a demonstration anymore.
Good.
Thank you.
Thank you very much. How much is the funding for the Maryland 2 facilities, do you know?
You could request up to $2 million a year for 2 years. So I know Cornerstone Montgomery got about 3.7 million. I'm not sure what was it. But it was probably around
Over a
that.
2-year period.
Over a 2-year period, yeah. So we're using it to kind of beef our services up and prepare ourselves to become a CCBHC if that happens.
Dennis?
Thanks for bringing that up, and one of the things that Dr. Burgess and I have talked about, and maybe this could be discussed at some point in the crisis services, as I've read the information, because we've met with some folks about this, is the thing that's most attractive about it is it's a 24/7 service, and we don't have that and a lot here across the state. So it raises a question in my mind, as we've got the Administrative Services Organization, which is has organized all the providers across the state. Does that CCHBC model then organize the providers around the state into networks?
It can. Every state is different. Some states have done it in a network type model. Some states, every provider becomes a CCBHC themselves. So every state has done it a little differently.
It'd be interesting to hear more about that down the road. Thank you.
Shannon Hall?
Good evening. I'm the Executive Director of the Community Behavioral Health Association of Maryland. Thank you for having this commission and creating the opportunity to have this wonderful discussion tonight. I think, like many other folks in the audience and on the commission, it's refreshing and inspiring, I think, to hear the level of knowledge from this body and level of interest in tackling these issues. CBH represents community-based mental health and substance use providers across the state of Maryland. On their behalf, we work to promote access to behavioral health services and improve the quality of services. I met earlier today with one of our members in Frederick, and they're not able to be here today, but I just wanted to share a little bit of my conversation with you, and then I could pick up a little bit on some of your CCBHC questions, sir. So I met earlier this afternoon with Behavioral Health Partners of Frederick. They're one of the largest outpatient mental health clinics in Maryland. They serve 5,000 patients every year in Frederick and the surrounding areas. They have a partnership with Frederick Memorial to provide rapid admission to folks being discharged from the hospital there with behavioral health needs. So I asked the CEO, what I ask all my members, what keeps you up at night? And I can tell you that the CEOs of community behavioral health systems are staying up at night thinking about the same things all across the state. What keeps them up, and what he's told me today, was that he can't meet the demand for mental health and substance use services in Frederick and every day, putting people coming in on wait lists, struggling to maintain caseloads. He said, the barriers that they encounter, you hear every day about, we read it all, about what's happening with the opioid epidemic. The other thing that they're seeing, I think, is what Mark Elrich brought up. I mean, this rising epidemic that folks on the front lines are reporting in youth and young adults. I mean, just a spiking increase in the need for behavioral health services. He identified 3 barriers that keep that organization from meeting the needs of their community. The first one, and I think Commissioner Redmer, this gets to the imperative of your work, is, he gets referrals from the hospital regardless of payer. Our hospitals are on an all-payer system. Our community behavioral health system is not on an all-payer system. We struggle to get in the door with the commercial carriers. Credentialing, rates far below the cost of care, and just coverage in terms of the benefit array with the commercial carriers. Very different from how Medicaid operates, and I think a real challenge to meeting needs in that community. The second one is that on the Medicaid side, we haven't really operationalized integration in a concrete way. They're licensed as an outpatient mental health clinic. they're serving people, people are coming to them with substance use needs, and there's struggles like we have to get a separate license to deliver integrated care. You know, there are a lot of barriers around that. So I think our continuing focus on making sure that our regulatory and licensing process supports the clinical product that we want and need just continues to need to be a focus.
Is that just with Medicaid, or is that just our general licensing at the health department in general?
Well, that's a great question, sir. Under the 1063 licensing, I think is where our folks get licensed, and that's where you license as sort of separate buckets. I know the Behavioral Health Administration, I think, has been working on a co-occurring licensing category, but I don't know where that work is. I don't know if you want to. Yeah.
Well, it just so happens I'm also the Chief Medical Officer of Medicaid. So you're right. It's a challenge.
Yeah.
We are working on it. As Mr. Schrader had pointed out earlier, we are taking advantage of being both under the Maryland Department of Health, and this is one of the reasons why we're so involved in this commission, and we're very grateful for it. But you're right. I'm go to BHAC, and my task is to be involved in all of our stakeholders and partners so that we can keep you updated as we work on this issue. We know that this topic of behavioral health integration is hugely important. It's also important that we be the model for that.
Yeah.
So I hear what you're saying, and we are working on it. Thank you for pointing out that we're doing that.
And then the third barrier he raised, and all of these are things that we all know and we're all working on, so I appreciate your attention to all of them. And the third one is the workforce. They cannot find and recruit psychiatrists and therapists for the level that they need. And the reimbursement rates in a highly competitive, under-resourced field don't allow them to do that. And that turnover, you hire a therapist leaves, that's a wait list, right? A vacancy in behavioral health is a wait list. That's a kid being referred to you that you're putting on a wait list instead of providing treatment to. So we all know that these are barriers. We're all working on them. But I want to echo my colleague Arthur Ginsburg's remarks that there are comprehensive solutions. They require funding. It's the Certified Community Behavioral Health Clinic model is a model that says what is the service delivery system that you want and need for mental health services? Do you need it in the police cars? Do you need it in the schools? And provides a mechanism and a model and a Medicaid state plan to deliver it. So that's out there, it's available if we have the political will to do it, and I urge you to consider that. So with that, thank you very much. Yes.
Yes.
Hey, yeah.
The issue of hiring recruiting providers, is it only an issue of reimbursement, or is there also an insufficient number of providers?
I think there's an insufficient number of providers, at least according to the federal look at it. So there's a core problem there. But then when you have an insufficient number and you have an underfunded community behavioral health system, we're kind of last in line for getting who's available without sufficient funding resources.
Thank you.
Yeah.
Can I add?
I was going to say, we've also heard that, and that's why we talked about the reciprocity in some of these areas, that if you're in the northern part of the state, there are people in Pennsylvania or Delaware that may be interested, or they relocate because they're, a military spouse or whatever the case may be, and they come to the area, but they can't practice here.
Yeah.
Or there's some period of time before they can practice, and so the provider can't afford to pay them if they can't see clients.
Right.
So that's one of the things that we're, trying to address as well, to see if, we can be able to at least make it easier to attract talent.
Yeah.
So,
Thank you.
I think, Steve, you.
Thank you. One other thing is, I think even if we had the providers, that one of the things that we see, there's a big workforce development issue as well, that some of them don't have the competencies to be able to treat people with co-occurring disorders. So I think, that workforce development is another issue, and I think you're alluding to that.
Yeah.
Thank you.
Yeah.
Steve?
Thank you, Lieutenant Governor. We've been, my office has been traveling around the state visiting with local jurisdictions to assess various behavioral health, particularly opioid-related programs. And almost every single jurisdiction has brought this up.
Yeah.
very serious issue, and it applies to all manner of behavioral health professionals, not just psychiatrists or even psychologists. And there are a number of things that have been suggested to us that don't require money, but would probably help. One of them is accelerating the hiring cycle times, that it takes local jurisdictions an incredibly long time to hire somebody, and by the time they get through their hiring protocol, the person's taking a job because they can't wait 3 or 4 months for a job. Another is academic requirements that in some cases are getting in the way of promotions and are making career tracks less attractive. And I don't know the ins and outs of that, but there are a certain number of credit requirements that we require for a person to move up, even if they've got 20 or 30 years of experience, that makes going back to school about the last thing they want to do and really isn't necessary.
Yeah.
So maybe we should look at that. Another is simplifying the credentialing process. Do we even need a credentialing process when we have JCO and CARF and other credentialing organizations, or maybe ours could be much simpler as a supplement to theirs.
Yes.
And finally, honoring other state certification programs. If a person's competent to...
That's the reciprocity issue.
Right. And one of the ideas that came up actually this very day, Lieutenant Governor, was maybe creating a compact of adjacent states where the adjacent states around Maryland, we all agree on a standard protocol and a common certification.
Well, that was one of the things that, we were suggesting, at least look at the adjacent states in our interim report and I mentioned that compact that Delaware is part of, at least with psychologists, that, look at what we can do to have this sharing, reciprocity, so that those who may come here, from other states are willing to be here, that they can work.
If I may respond, though,
Yes.
those are all great ideas and really creative non-funding based solutions. And I think they're all good ideas. But increasing the workforce overall is part of the solution. But like Commissioner Redmer said, it still doesn't get to that, compared to hospitals or education systems where our folks tend to have lower salary scales and a little bit more of a, feel like, at least what my members reporting, at the back of the line in terms of getting these folks. But there are equally creative ways of getting to that, also outside of the funding. I think in Florida, they've conditioned their state loan repayment programs on graduates going into community-based practices to qualify for the loan repayment, because absent that, folks tend to find the highest paying job. So there are ways, A, to lift the overall workforce, but then also to sort of say, our priority is helping to address it in the community setting as well.
That would be, that's a good idea, and particularly in our rural areas of the state, too.
Yeah.
So, okay.
Thank you.
All right, thank you. Marty Birnbaum? Thank you.
Hi, my name is Marty Birnbaum, and I'm a licensed clinical social worker. I'm from Pathways Substance Abuse Treatment Program in Anne Arundel County. So I did come here to make some requests, ask some questions, but I would also like to respond to some of the excellent comments that you all have made. And thank you all for your work and for taking this on. So the first comment I want to make is, and I applaud Mr. Shu's group's efforts to really kind of highlight, we've really got to get our terminology, be talking on the same page. That's a great place to start. And everyone has those same kind of confusions about the terms. So what a wonderful place to start. And what I want to point out about that is that whether you, once your mental health issue or your substance abuse issue has progressed to the point of problem, and you become diagnosed, you're diagnosed out of the same diagnostic and statistical manual. It's the same DSM, whether it's substance abuse or mental health. And so what happens after that is it splits. And so to me, that's kind of a false dichotomy, is, that it splits from there. And I'm going to address that with what I wanted a request I wanted to make. But I wanted to point that out to your discussion. To your discussion about the workforce, there are also other things. For example, with substance use, we have done a lot of work. I'm sure most people here have heard of peer counselors. and the peers. But the peers are not licensed by any board in Maryland. So that's an issue. They have a board, it's sort of a voluntary board. They do excellent work. And we've got peers all over the place doing stuff. So if there was some licensing, credentialing entity for peers, right there would increase our workforce, at least as far as substance abuse, but probably something similar could be done for mental health. So that's just a thought. And then my last kind of response, I have many, many things that I'm thinking of to what you've said, but save them for another day. But, I appreciated you bringing up about deinstitutionalization, because then probably people do know that there was really no act which created deinstitutionalization. The act was something like the Community Mental Health Services Act. And we're talking 50 years ago, and it was supposed to create a network of care where you didn't have to be warehoused, you would be treated in your own community, and there were some efforts made. But I think that failure 50 years ago has kind of led us to where we are. So I hope you all are going to meet for a while and be tackling this, because it is a big problem. I can't think of anything more worthy that you could be working on than this problem. What I came here to say was that looking at the system, as you are, you really have an opportunity in looking at the mental health system and the substance use system to look at the co-occurring disorders. Now is the time to develop such a system. And if you've been working in the field or dealing with this for any length of time, really most people do understand that it's an overlapping problem. And so, back in the day, you looked at primary, or you figured out, do you go here first? And then, or no, you go there first. And we're still there, and we really can do better than that. We have separate regulations, we have separate financing, we have separate oversight, we have a behavioral health system over 2 silos. And, but the people have the same issue. So the silos are not helpful. So if you all just, went back to your departments and said, hey, every unit, look at how you, substance abuse unit, do you have any barriers to someone delivering both the services, and vice versa. We could probably come up with a lot of things. And I think the bonus is, I think it would be cost effective to treat both the issues at the same time. So that was one point. My second point is medical necessity. So everyone's heard about the issue of medical necessity if you're dealing with parity. And yes, Virginia, it is still a problem. You will have heard the emphasis on the acuity nature. So what that means is that if you are a person, and I'm talking about substance abuse now, if you're a person who abuses benzodiazepines or you abuse alcohol, then withdrawal is a very, very serious issue. Why? Because there's a risk of seizure. But if you are abusing opiates, there is no seizure risk. You don't meet medical necessity in and of itself. So since there's no seizure risk, what our people who are trying to help someone access their insurance or their Medicaid, their private insurance or their Medicaid, and Pathways serves individuals with both, we get asked about DTs, we get asked about seizures, we get asked about blackouts, and none of those apply to someone who's taking prescription pills. Not one of those things applies. So we suggest that something that's relevant to opioid use disorder, such as a history of overdoses, be asked when you're assessing someone for an opioid use disorder. There's really no reason why someone who has had 8 overdoses does not meet medical necessity criteria when any one of those overdoses could cause them to die. And the very last thing that I wanted to say, and we're talking about workforce, and I think this impacts a lot of issue. And I brought a paper, and I'd be glad to give it to anyone who would be willing to take it from me, is that we worked really, really hard on the Keep the Door Open Act, which got rolled into the HOPE Act, and there were fee increases for providers built into that. And so just in particular, substance use programs, on July 1st, the new rates came out, and so None of the level 3 programs are included in that rate increase again. This is the third year in a row. So, I mean, even from there, you can see this chart, and all that yellow on the chart are the fees that were not increased. But in the HOPE Act, it says that they were to be increased. And so that means detox, rehab, same fees as when those programs were first started. So I don't think that was the intent of the act, and I just wanted to point that out.
Thank you. Thank you very much. Okay. Anything else? Laura Willing.
Hello, my name is Dr. Laura Willing. I'm a child and adolescent psychiatrist at Children's National Health System in Washington, D.C. I want to thank you all for tackling this huge, complex, but vitally important issue. I'm encouraged by the depth and breadth of the discussion that I've heard here already. I wanted to take this opportunity to give you a little bit of information about the scope of what we're seeing in our health system, and then give some ideas of what I think might be helpful. Children's National Health System provides inpatient, emergency, and outpatient services in DC and in Maryland. We have 2 regional outpatient centers providing mental health care in Maryland, in Rockville and in Laurel. From our emergency room in Washington, DC, we see about 2,341 psychiatric evaluations a year. This is just for children. We also, I'm sure you guys are also aware of the emergency room boarding crisis. So when there are not enough inpatient beds, and these are for children that I'm talking about, we have anywhere from 0 to 88 children boarding in the emergency room waiting for a bed each month. For fiscal year 2019, it was 492 total boarders. That's children just sitting in the emergency room waiting. In the inpatient unit, we have a child psychiatry unit inpatient and an adolescent psychiatry inpatient unit. We had 463 children admitted to our child psychiatry unit over the past fiscal year, and 586 admitted to the adolescent psychiatry unit. About 30 to 35% of those patients are from Maryland. They live in Maryland and they're coming into DC for care. In the outpatient setting, we see approximately 900 outpatients for new patient evaluations in our outpatient setting in DC. 45% of those are from Maryland. There's a lot of kids coming to see us for treatment, and our wait list is 2 to 6 months. 2 months for just a general psychiatry evaluation, 6 months in some of our more specialty programs. In Rockville, the wait list is 2 months, and we see about 184 patients, new patient evaluations a year. Part of what is stemming this problem, the wait list, the boarding crisis, is the shortage of mental health providers, including child and adolescent psychiatrists. There's a national shortage of psychiatrists. There is an even more severe national shortage of child and adolescent psychiatrists. At Children's, we've had several open positions for several years for child psychiatrists. As many people have already brought up today, I think mental health parity is part of the solution to this problem. I will refer you all, I'm sure many of you have already read the 2017 report by the actuarial firm Milliman. It really outlines that there's severe network inadequacy in many of our health plans. Our patients cannot find care. There's a reason that they're coming to the emergency room to get care when they've been on wait lists to see psychiatrists and therapists in other places. There's a reason that people are driving from Anne Arundel County to DC to see me and waiting on my wait list for 6 months. There's not enough psychiatrists or therapists or other providers in the state of Maryland or anywhere in the country. This is not a unique to Maryland problem. We need adequate networks, and we need parity in reimbursement also to help improve those networks. We also need more resources for children needing psychiatric care in the state of Maryland. This is a whole continuum of resources. So we need more inpatient care, we need more outpatient care, we need more partial hospitalization programs, we need more intensive outpatient programs, we need more residential programs, we need more evidence-based therapy, we need multi-systemic therapy, we need dialectical behavioral therapy. We have lots of people working hard, gathering data and getting evidence that these therapies work. And I see a patient and I say, aha, I've identified the problem and I have this evidence-based therapy that data shows will be helpful for you, but there is none available, frankly, in a tri-state area. So I think if we can work on improving our whole spectrum of care, that will help reduce pressure on just using the emergency room for crisis services. And if we work on mental health parity, starting with transparency, I'm encouraged by the initial interim report that you already have. If we can work on improving transparency, and then the next step would be work on parity enforcement for these health plans. Thank you.
Why is it that, and this is just not locally but nationally, that we have a shortage of psychiatrists? I mean, doctor, you're a child psychiatrist.
There's a much severe shortage of child and psychiatrists.
Do we know why? Is it that the people are not going into the field? And
It's not that the people are not going to the field, the programs that are really being conducted. I think the demand has outpaced the supply.
okay, okay.
Demand for the services that outpace the number of licensing programs and fellowship programs that can produce the output to meet the demand.
It's my understanding too that some of it is that most, at least in psychiatry, it's older, they're retiring, and there aren't enough people to fill those spots. I mean, that's what the research has shown too, that there's some of it is people are retiring, there aren't enough.
And you just don't have
and the need is increasing. We just can't catch up.
And let me add something to this. This is probably a topic that we probably don't talk enough about, but certainly this is a forum for it. So it has something to do with stigma too. And those of us who are in the clinical realm, we know this. Those of us who went to medical school, we know this. And so it's someone pointed out, it's not just a United States problem. This is a universal issue. I wish I knew another word than stigma, but I don't. So, it's how we value this field that we're in. And can we increase that value? I know that people questioned why I went into the field. And so my understanding is even within the field of behavioral health, there's stigma from those who have substance use disorders, those who have mental health issues. So, and one would wonder, does it start with the curriculum, with education? And I would even go as far as to say, does it start in our schools before we get to college, and our media? So this is a systemic issue, and so that's one. The second thing is, when you deal with psychiatry, you're not just dealing, with a person that comes into your office and they leave. And even more so as a child psychiatrist, right? So you're dealing with the family, I'm dealing with the schools, I'm sometimes dealing with the law enforcement. I mean, I love what I do. I am a child psychiatrist also. But when you think about what so yes, you know what I'm talking about, right? And so I think that all of those issues I think we can start addressing some of them. But it really requires us to have this frank conversation. Sometimes we don't want to talk about the fact that this is a field that's not really respected. And on the other hand, I will say that colleagues who have had experience very much respect what we do. So I know I feel like I'm talking both sides, but I think that's the nature of what we do. It's complicated. It's not just one or the other. But I do think that this commission lasting more than a year or so will advance that ability for us to continue to have this in our public domain.
That's a very good point. I mean, because we know that, mental illness is a major stigma associated with it. Years and years of media, from horror movies when I was a kid that, made it something that was scary. And then, the jokes and other things that have gone on that have made a major stigma when you even talk about the area. People don't want to talk about it. They don't want to come forward if they have a problem or they have a family member with a problem. We've talked about stigma with substance use disorder, but it's much more so when it comes to mental illness and mental health. And so thank you. And that brings up a point, too, in terms of adolescent care. And I was going to ask, I'm not sure if Dennis or Dr. Burgess are in communications. The new hospital that's going in Prince George's County, I had one person that talked to me about a concern about not having a psychiatric room for adolescents. They're putting in a psychiatric unit, but nothing for adolescents so that they don't have to go down to Washington for service for the young people. So I don't know if either one of you are in contact with it's University of Maryland system, I guess, or the hospital, University of Maryland Medical that's doing this.
I might add, having been in the system for a while, we used to have child and adolescent units. I know on the Eastern Shore we did, and I know we used to have those in the Baltimore area. We have nothing right now on the Eastern Shore. We had our last residential treatment center closed about 3 years ago, and so there are just no services. And yes, and for children. And we're just talking about substance use and abuse and mental illness. I'm not even talking about some other autism, other issues. We just have no beds. And that's a major issue I hear about from constituents all the time.
And I just want to go back to something that county executive was talking about in terms of visiting the high school and what a lot of these kids that are, suffering from, ranging in, I guess, depression from early minor depression, mild depression to something that is clinical. And I'm going to sound like a cranky old man right now, which I am. But it is, social media is part of the driving force that you and I didn't have when we were in high school. And so, I mean, I look at my son's social media. Now, he's 30 plus years old. But you look at it, and I know him, but looking at it on the outside, he's living the best life in the world. Because on social media, you show all your fun stuff. You show when you go on vacation, you show, eating some food at some restaurant. But you don't see when, things aren't going so well because they don't put it on social media. So if you are, a kid and you're, maybe not quite as social, you may be socially awkward, or you're not out there talking to people and you're looking on social media and it seems like everybody's having a good time but me, and it can then further, isolate you. And so, but I'm being a cranky old man, and I won't get into the video games and all that too. But yeah, it used to be, your parents say, go outside and play. Let me introduce you to some people. Go play. And so it's, yeah. In my day, speaking of not an old man, I saw Councilman Rice come in. Did you want to address the group? He's hiding in the back. And on your comments, the county executive.
So we play tag team.
Okay.
Lieutenant Governor, let me just say thank you. As chair of the Education Committee for Montgomery County, but also as the chair of the Education Committee for the Maryland Association of Counties, let me just stress what you talked about in terms of the importance when it comes to our young people and ensuring that their mental health is paramount. It really is one of the things where was just reported about chronic absenteeism when it comes to Montgomery County Public Schools, one of your largest, the largest public school system in the state of Maryland. And quite honestly, as I can tell you, in being able to spend a lot of time with a lot of our counselors as well as our school resource officers inside our schools, a large portion of that is mental health days. Our children are actually taking days off to where they are completely exhausted from the trials and tribulations that we didn't experience. I mean, as I heard you talk to the county executive, it's so true. The same thing exists even in my generation. It's a little bit later than yours, but still is the exact same thing to where we don't, it's just small, just a small window. But it really is one of those where we have to start to understand that these are the kinds of things to where parents are actually even calling in and saying, I need to have a mental health day for my child to get them away from the stresses and the challenges of what we see. And just as you said, and you commented about social media, I just want to highlight that and have us really reflect on the fact that if you're the person who has parents who are struggling to be able to afford the cell phone for you so that you can keep up with the Joneses, and then you hear and you see on Instagram all the great things that your other friends are doing and how your life is not the same. All it's doing is highlighting for them the differences in terms of where they are and different. And these are the things that we're hearing from our kids as you talk to them and say, this is even more so talking about how these kids' lives are so much better than mine, and my life is horrible. And my life isn't good because those kids are going on vacations and going on trips, and here I am stuck and can't do whatever. And so you're right, social media plays a key part, not in terms of just internalizing and making a front in terms of how my life is great, and it's really not, and I really don't feel great about myself, but it also makes other people feel less positive about themselves. So just wanted to share that with you, something that we're seeing in our schools and when it comes to the mental health of our children, it's really something that we need to continue to prioritize, which really comes down to ensuring that we have additional counselors and resources inside our schools. So thank you.
Thank you. And Oregon recently, implemented mental health days. I guess I had a slight difference when I was reading about what Oregon did and just said that they should just be included with sick days and not, have to classify that it is a mental health day, and just fit into that. And again, not being the education expert, but one of the things that maybe our school systems, I was going to talk to Dr. Sammons about it, is that why not have mental health days at school where kind of all your classes, you talk about mental health. I mean, and it can be, and even relaxation exercises. I know they have to get through criteria, the curriculum, and they have to do the test and stuff like that, but there's time that even in a math class that you can say, we're just going to do third grade math today in high school or for the first hour. Here's a sheet just like what you had in the third grade, or second grade. It's just 1 + 1, and just something to let kids relax a little bit after they laugh for a while, but get them to relax, and then you go back into, but you can do that in your history class. You can do things in your science classes and talk about, like you said, brain disease, just things that can maybe lower the anxiety that some kids have, because we need to bring their parents in because many of them put the stress on the kids. Got to get into the good school. You got to do this. Great thing about our country is you can go to any school and you can reach the highest. You don't have to go to a college to reach the highest levels. And many of our entrepreneurs and the richest people in the country dropped out of college. So, sorry.
Yeah. No, go ahead.
Thank you, Lieutenant Governor. And it's really interesting. I do character counts in our schools in Dorchester County. And one of the interesting observations I've made, we've had at school that was designated needing extra mental health professionals. And over the school year, one of the things I watched was teachers in the beginning of the day with kids that were fifth graders, and they're getting ready now to transition into the next level. But these were very needy kids, and every day he would get all of those students together Indian style in a circle, and they'd talk about what they brought to school that day. And then they'd wrap it up at the end of the day, and I thought that was remarkable because it was a great way to let the kids either vent or chill out, if you will, so that then they could go ahead and be focused in their learning. So I think there are a number of very creative interventions that are going on to address the anxiety level of the kids in our classroom. And certainly some of those good examples are being shared. But you're right. Those are the kind of interventions that I think make a difference with a student's ability to focus and learn.
Yeah, and I just wanted to agree. One of the other things we see is a lot of schools using things called mindfulness activities, mindful moments, mindful rooms that help kids become centered and focused a little bit, usually with the support of an adult who's there with them to kind of guide them and kind of help them to reflect. We also see a lot of schools implementing restorative practices and using circles as a way to build relationships and to enhance connection between students and staff and schools. But it's something we do need much more of. But, you know, we have seen some really promising practices with that.
Good, thank you. I didn't have anyone else signed up, but if anyone wants to speak.
Good evening. I'm Dr. Raymond Kroll. I'm the director for the Department of Health and Human Services here in Montgomery County. Thank you all for taking the time to do this, and I will be brief because the hour is getting late, and I know folks do have other things they want to do. A couple of things. On social media, just to say this to you, I think social media is a reality of our system. It is not going anywhere. It's not going away. And as a device, it is neutral. It's the content and how we use it. As an example, we have a young man in Montgomery County who invented an app called Take the Pledge that is targeted to high school youth. And I'd invite you to just go and Google it, Take the Pledge. It's about 5 things that you do for yourself every day. And he has a suggestion for every day and think that youth can do. To the comments I've heard here this evening, Kerwin and K-12, K through 12 is an interest of mine that has been a lifelong interest of mine. I think or K through 12 has been an interest, and I think to the extent that we can coordinate and integrate the work of behavioral health across the state with what's happening with Kerwin, so that they align and integrate in a way that helps us to do our work collectively for our children would be helpful. School isn't just about depression, it's about anxiety, it's about stress, it's about fear, it is about needing a mental health break, and sometimes you have to take one before you really need one, and our kids sometimes don't get a chance to do that, so those issues are important. On the issue of transitional age youth, I think we have, and tied to school, we have a process of youth becoming disconnected from us and disconnected from everything that's important as they age out. And in mental health, I think that's true. They turn 18 and they don't have anything to do with us. But that process starts with disengagement in schools before we get to disconnection. And so recognizing that we have to go up front and go upstream and think about how we support and support providers to do things that help us to get kids to re-engage and stay connected to kids rather than letting them start to disengage and pull out. When I hear system of care, I think about promotion of an integrated system that starts with promotion of wellness, prevention, treatment, and recovery. I worry that when I hear systems of care here, I don't quite understand what it means necessarily, but it could be primary care and behavioral health, but we got to get behavioral health squared away and integrated, I think, as we go down this path. You've heard a couple of times about staffing tonight. We have, in workforce, we have a real shortage. Psychiatry, nurse practitioners, social workers, numbers are going down. The cost of education, has just skyrocketed for folks. And when you look at the math around what I'm going to get paid as a social worker or a nurse practitioner or a psychiatrist in public service versus private practice, the math is compelling to pull you out of the system or to get you to go into another field. So we've got declining interest in this, and I think that at some level we need a pipeline process, whether it's loan forgiveness or incentives to encourage high school kids in community college to try to move in this pipeline and figure out how we support them. I think that is something that we can do locally, some things locally with, but having some state support and some state engagement in that process would be very helpful. I think the last thing, parity has been talked about, so I won't dwell on parity, except to say that one of the challenges we have with ACA in the exchanges is that we have folks in the exchanges who have insurance coverage that is catastrophic coverage, who could go a full year and never meet their deductible, but who have mental health and substance abuse issues. Those folks end up being a burden back in the public system because they show up in the emergency departments, they show up in our public clinics, and we end up having to figure out how we cover the cost or say no to them. And then the last one, back to staffing, is that we have a diversity issue in the pipeline as well. We've got an incredibly and increasingly diverse county and state and country, and the folks that are able to afford to go to school, who have capacity to go to school, don't represent the diversity of the country and the state right now. So we need some attention to that issue as you all think about what you're doing and how we go forward in the state. So thank you all.
Thank you.
Good point, thank you.
No, I thought you all were racing it.
I know, Brian's leaving right when I'm ready to talk. Good evening, Lieutenant Governor, members of the Commission. My name is Eileen Cahill. I'm with Holy Cross Health in Silver Spring, Maryland. And I was not intending to talk today, but I just heard some things I would like to elaborate on. Workforce clearly is an issue. And also is the disconnect between psychiatrists and therapists. Because often patients go to both, but the two aren't talking to each other. And that's a really key component of integrated care. That overall sense of somebody's seeing all the facets of your care.
Can I just say something? Shannon said integrated care. That was the word I was looking for earlier when I was talking about holistic. So, okay, continue. That was just commercial interruption there.
I know, because I really do workforce issues. So I would also say you need to look at bed capacity in the state, inpatient beds, for adolescents, but also for adults.
Yeah.
And I would also say I think there's been a big advocacy for children and adolescents today, which clearly needs to be done, but we also need to talk about seniors. And one of the biggest declines of health among seniors is social isolation that leads to depression. So we need to think, as people are aging in place and aging in their homes, when they start to become less mobile, how do we integrate them into community? So I just raised those points, and thank you for your time.
Yeah, no, that's a very good point. Depression, and particularly when they become less mobile, when they stop driving, that is a big factor right there. Oh, wait a minute. Wait. Question?
I was fascinated by your point about increasing the bed capacity. Are you talking about within the private hospital system, the 48?
Private, public. I'm not a clinician. I do advocacy for Holy Cross. But because I work in healthcare, and probably a lot of you know this, when you work in healthcare, everybody assumes you're an expert on everything. So I get a lot of calls from my friends and friends' family that are dealing with mental health issues. So they're always asking me, so for recommendations and things along those lines. And I hear about their journey. And a lot of them are going into emergency departments. And someone mentioned, the lady from Children's was talking about boarding in emergency departments. You wait for a bed to open, and then you might get discharged from that facility because they're at capacity and they're being sent out of their community. And especially true for children. I mean, a lot of those folks in Montgomery County, they might go to the Adventist healthcare system has an inpatient unit, but they're at capacity, so they're going up to Hagerstown. I mean, that is just a tremendous burden on families to want to be there for their child, but having to drive 2 hours so they can see him on a daily basis. I do think that there's just based on anecdotal experience of people I'm hearing about, when they ask me for some suggestions and I just stay engaged and connected with them, a lot of times they're leaving Montgomery County because there's not enough. And even then, they're going also down to the district because there's not enough bed capacity, so.
Thank you.
Sure.
I think that's a wonderful point. The Lieutenant Governor has actually charged us with looking at service capacity for the entire state and looking at not just beds, but looking at inpatient, outpatient, detox, everything.
Yeah,
And just to see what is it that we have and what is it that we need.
The fragmentation of care on behavioral health, both from the mental illness side and the substance abuse side, is it's heartbreaking. It's not just here in Maryland or Montgomery County. We know it's a national, but it is heartbreaking. And when you can't help your family member, your friend, oh my goodness, it breaks your heart.
Absolutely.
Thank you.
All right, good evening, Lieutenant Governor and Commission. My name is Ken Alford. I'm the Systems Director for Behavioral Health at University of Maryland Capital Region Health, covering Bowie, Laurel, and Prince George's County. We today are very happy to be here to kind of share some of the work that we're doing with mental health and behavioral health, as well as some of the concerns that we have in terms of moving forward in the future. Our current state at University of Maryland Capital Region at Prince George's, we have a 32-bed inpatient unit. That unit is broken down to patients that have what we call high acuity, which means that they come in with florid symptoms of psychopathology, they're floridly manic, schizophrenic, and really need acute treatment. About half of those patients are actually brought in through emergency petition, and I think you mentioned that earlier, the process where the police will bring them into the emergency room. It might be a family member or a parent or even a community friend that has recognized the person may be in distress. They activate a forensic response. The police come in, they bring the persons in on emergency petition, and they are in our emergency room to be placed, to be evaluated, and then see if they meet eligibility either for an inpatient service or something less, a lower level of care. What we're finding is our emergency rooms are really being overrun. We are stressed. Particularly on the weekends, between Friday and Sunday, we have surges of behavioral health patients literally that are in our emergency room areas where patients are getting treated for car accidents or whatever services are in the ED. Our psych patients are right there. And then we try to work fast to process, evaluate, support them, and get them the proper treatment, but we don't have the resources. And as already mentioned, our patients are then being looked at other areas in the system, in the state, and that can take hours. Usually it takes days, particularly if it's an adolescent. They'll stay in our emergency room for days until we find beds that are open for them to be safe. And then add to that burden, if the person has acute suicidal ideation, Joint Commission has really increased its standards on how hospitals manage those type of patients. So we, as a hospital system, have to now supply one-to-ones for everyone that comes in with acute suicidal ideation. And so the system is really burdened where patients, our employee staff that normally would be treating medical patients are now deployed to do one-to-ones on patients that are expressing suicidal ideation. So we really are in dire need of support and ideas. As our system continues to grow, we had the closure of Providence Hospital. Another hospital system recently, Tacoma Park, has been shifting its behavioral health beds, downsizing, and we're seeing these involuntarily committed patients show up at Prince George's Hospital. Same level of resources, but more people entering the system and really taking us to stress level. So what we are asking or proposing is that we need maybe like a psych urgent care where we can use some of that space to decompress our emergency room for patients that may not need acute involuntary treatment, but maybe can do something at a lower level. Could we use an ACT team that could really follow the patient in the community, not just have the emergency room as the first source of treatment, but perhaps follow them where they are. If they're in the school, if they're at home, this team could follow and support their care. And also a safe place for our minors. Our current state is our adolescents sit in this emergency room with adults, with other emergencies, and again, causing trauma for them, seeing the other things that's happening around them. So we know that the emergency room is not the best place for patients in acute distress. And then finally, looking at what happens to our patients when they're discharged. We're finding that homelessness is a big factor. We are stressed to find placement that is a safe discharge. So they go home with treatment, but then who follows them 10, 15, 30 days later, or they show up back in the emergency room 5 days later with the same level of pathology. So thank you, Commission. Thank you, Lieutenant Governor.
And I think the conversation earlier about and I don't remember, Shannon had mentioned it, and you're currently piloting, tell me what it is again, CCBHC. Is a step in that direction in terms of a diverting so that they don't go into the emergency room?
And it has to include a lot of things he talked about, ACT team, an assertive community treatment team,
Okay.
and You know, having people follow patients when they're discharged from the hospital, having a place for them to go. I mean, it has to include all of that.
Right, right. So
We look forward to it because we definitely can use the help. We're trying to find creative ways to manage our patients, so we look forward to that model.
now, as the new hospital is coming in, have you talked to them at all about having adolescent facility within the hospital?
So the good news is that we have our new CEO, Dr. Wright, Joseph Wright. He actually is committed to child and adolescent services being provided in the community. The current model did not include adolescent and child services. However, there's some rework that we have to do because of community need, particularly in Prince George's.
Right.
We need to relook at that new space to see could we do a model that would support children and adolescent services. So there is serious conversation being developed in our boardroom to figure out what we do next.
Okay. All right. Thank you. Thank you very much. Thank you. I see Delegate, I don't want to pronounce your name wrong. Acerio? Acedero. I got the accent in the wrong spot. But thank you. If you want to say something as well, maybe after the young lady. Yeah,
go ahead. I'll try to make this quick.
Since she beat you to the podium.
Sorry, Delegate. My name's Donna Cronin. I serve as counsel to the state's active assailant interdisciplinary work group, and I also serve as counsel to the Maryland Center for School Safety. So the active assailant interdisciplinary work group asked me to come and sort of take a look at what you were all doing, because one of the mandates of the executive order that created that as a public body required prevention. And I co-chair the prevention subcommittee of that work group. So what we are learning through our work there on the prevention subcommittee is, again, these problems with the revolving door, where law enforcement and some law enforcement units that have crisis intervention teams that are partnered with them and have formalized partnerships still are unable to ensure that those folks don't end back up out on the street or end up there, because there is only so much they can do and many restrictions with how they can, in fact, interact with those citizens. So that is one bucket of problem over here. On the school side, and Secretary Padilla sits on the advisory board for the Center for School Safety, and we work very closely with Dr. Nelson. The 24 mental health services coordinators that each local school system had to have in place by the start of last school year, the Center for School Safety is now conducting monthly meetings with them to try and find out what their challenges and issues are. And the intent of the group and request was that they also have quarterly in-person meetings where they are able to roundtable and discuss those issues. The Safe to Learn Act of 2018 also required a 40-hour model school resource officer, a school security employee curriculum that all of the SROs and school security employees in the state of Maryland must be trained in prior to September 1st of 2019. And we have about 4 more weeks left to go of that. So I've been traveling across the state serving as an instructor in that program. But a lot of the issues that you have all discussed in terms of adolescent behavioral development, trauma-informed interventions, restorative practices are all modules which are included within the instruction that all the SROs and the school security employees are receiving as a part of that 40-hour curriculum. So just wanted to provide a little bit of an update about the things that are going on in that context for everyone. Yeah.
Thank you very much. Delegate?
Well, good evening, Lieutenant Governor, members of the Commission. My name is Delegate Gabriel Severo, and I wanted to welcome you to my district, District 39. I'm an alum of Montgomery College, so really glad to see that we're convening what is a really important conversation in an institution such as this. I want to also acknowledge my colleague, who's a council member for this district and used to be a delegate as well, Craig Rice. In the back.
He spoke a few minutes ago.
Yeah, I'm sure. So,
okay.
We still on for drinks, right, Craig? We still on? Okay, great.
But I think you're buying.
Right. Let me just say I'm here to listen and to learn. I think we have certainly come a long way from what was then the Maryland Department of Health and Mental Hygiene. And I think it was important for us to not just change the name, but change the way we view and interact and serve those with mental health issues. And a big part of that is not seeing them as individuals who are broken or who are in any way unclean, as the word mental hygiene used to suggest, but these are, in fact, Marylanders who need the kind of help and support, not just from institutions and organizations, but from the community. I'm reminded of the words of Audre Lorde, who said, without community, there's no liberation. And so it's really important for us to understand that those struggling with mental health issues, in fact, need our support and not our very unsavory gaze. So with that, I'm here to listen, I'm here to learn, and certainly looking forward to working with this commission and the Lieutenant Governor in my capacity on the Appropriations Committee, because everything that we do and everything that we study comes with a price tag at the end of the day, and we need to ensure that we're, as it relates to the budget, we're providing for those most vulnerable and those that need it the most amongst us. So thank you very much for being here, and I look forward to listening in and being a part of the conversation. Thanks.
Okay. Thank you. Unfortunately, you've missed the majority of the program, but we will be having additional meetings like this. The next one will be in Western Maryland. We haven't decided exactly where we're going to be at this point, whether Hagerstown or over the first set of mountains in Cumberland. But we are going to be doing that. We also need to get to the Eastern Shore. Yes, we need to get to the Eastern Shore. Well, we wanted to get to the west before it starts snowing. But it could be snowing when we get there, but it'll be lighter snow. So we know the shore is always wonderful. So we'll get there, and probably in the northern part of the state, Baltimore County or Carroll as well. So any additional people wanted to speak? And Delegate, I'd also refer you to our interim report. It just will give some of what we've done so far and some additional information. But thank you.
Thank you for letting me speak. I'll make it real quick. I know everybody's anxious to get home. Here today, my name is Christina Callender. My job today is mom of an adult with an addiction and mental health issue. My child was diagnosed with post-traumatic stress and depression. I'm one of those moms. Mm-hmm. I go through the doors of party houses and I drag my child out. There's so many things that we parents see that maybe the private and business or medical sectors may not see, that we can introduce to the committee as a problem. There are some inconsistencies when we see our child go to, healthcare centers. I can speak, as I was listening, I kept thinking, oh, let me tell you a story about that. Let me tell you a story about that. I was hoping today that I could come and maybe talk about if we could get a parental committee together to be able to present those issues and the things that we see to the committee, and maybe have an interim so that we can come up with or solve those issues. One of them was, I heard somebody talking about the emergency room. I was in the emergency room and my child wanted to go to a rehab, and we were told, sorry, we don't have the bandwidth to help you. You'll have to call tomorrow morning at 9 o'clock when they open to see if you can get a bed. That was not acceptable for me. My child wanted to go right there and then. Mm-hmm. I needed her to live. And if I let her go, I didn't know what was going to happen when she walked out that door. I've walked into a plasma clinic in Glen Burnie where she was about to sell her blood for $200 to go buy drugs. That's not acceptable. I'm a parent who's seeing these things happen, and I want to make sure that we can bring it to light and find solutions for that as well.
Well, I would ask you, there are a couple of areas that we have set up subcommittees. One is the youth and families. And when we say youth and families, we're not just talking K through 12 kids, as was mentioned by the secretary, adult family members, that it is very difficult to get assistance because she's considered competent. In the eyes of the law, she's considered competent. She can't sign a contract because, you know, she may be under the influence. But in terms of her medical, in terms of her privacy, in terms of substance use treatment, she's considered competent and is protected. And so we have to find solutions. And like I said, that the CORE Act, which was, or CURE Act, excuse me, which was federal legislation a couple of years ago, was supposed to address part of that. But I don't think that they promulgated the regulation so that you can talk to the providers on that. The crisis subcommittee, crisis service subcommittee is looking at, and it's sporadic, some counties have 24-hour, 7-day-a-week crisis services, which would address the situation that your daughter was in, because as you know better than I do, or as well as everybody here, when a person has substance use disorder and they're ready for treatment, they need it then. Because if you wait longer, they're getting sick.
Mm-hmm.
And once they're sick, they're going to do anything they can to not be sick.
Absolutely.
And so, we're trying to, see where the gaps are, because not every county has the 24-hour crisis services. Some have them, and some have kind of a hybrid of it where it's not on the weekends, which is the big surge that occurs. And so we're trying to address those issues and come up with, recommendations, solutions, and where we will need funding to do that. And in some cases, it's not just, new funding, which I would say to the delegate, it's making sure the funding that we're utilizing, like how much is being spent in Medicaid and even on the private insurance, is going to the right places. That it's being spent wisely, because there are, providers and there are other things out there that are not really providing the services that they should, or the quality of care. And so we have to look at that. But I would encourage you to look at the work groups that we have.
You can participate in them. They're public.
They're public, yeah. Yeah, we're not a closed group. The commission is set up, but we've created the work groups because we're not going to do everything at the commission level to bring, recommendations from the work groups, which are public, and we're actually putting information on our website that of when the meetings are taking place and suggestions that come out of there.
Perfect.
So you can participate, yes.
I'd also like, Christina, if you would have a few minutes to stay afterwards, I'd like to talk with you.
Sure.
I'm also a parent who's lived it.
Okay.
So I have some other suggestions as well.
Thank you.
Yeah, we made it a point to have a commission that had, as many voices as possible, and particularly people who've experienced the issues that you're going through. So I know we all sit up here looking pretty and stuff.
No, I know.
Yeah.
I know
But
that. I just,
okay.
there's so many things that you learn when you're doing the parent side of it. I've worked in the Medicaid field for 24 years, so I've already had the mental health on the clinical side, but now I'm having to deal with it with a child. And
an adult child.
An adult child, and this is a whole new experience.
Right.
So, and I've been called that mom, but that's okay.
That's okay.
That's okay. So, thank you.
No, thank you. Well, if we don't have anyone else, then I want to thank everyone for participating, for being here. Thank the commission for being here and participating. We will be, once we get our minutes, we'll post them on our website. We'll post the minutes that have been approved on the website. The next meeting will approve the minutes from this meeting, and they'll be posted. You can also submit comments if anyone wants to submit comments regarding things that we should consider. You can send them, and I think we have the email address up here. Do we? Yeah. Okay. I never look up. And I'll say that we have a website. I don't know what the website address is, and it's sitting right on my head. Okay. So thank you, and we'll let folks know when and where. Like I said, we're planning to go west next time, and that'll be out on our website, and we'll put information out about it. So thank you again.